we have data, brilliant. We have data in STARR tools that goes all the way back to the late 90s. And but you'll see here that for the first decade or so, there was a sort of very steady state. The number of patients, this is the number of patients per year, the number of patients stayed quite flat. And that's because at this time, the two hospitals were just that, they were just hospitals. They were tertiary care facilities for all the people you would helicopter in from Djibouti with their kid and drop them off at Packard for a life-saving cure that was, but they didn't have any clinical outreach to the outpatients clinics. And then sometime around 2010, they started doing this. They started building all of these outpatient clinics with affiliations of all these primary care offices. They bought a hospital in here. So the outreach of Stanford has been climbing steadily since about 2010. So I think that's kind of cool. I like knowing that Stanford continues to grow in the community. And if anybody wants to intercede and make comments, please feel free. This is, I'm nearly done with the prepared presentation, and then we'll get around to playing on computers. So I did want to very briefly get on my soapbox and warn you folks about the pitfalls of using clinical data for research. It's fraught. The point of these electronic medical records is clinical care. People using the clinical systems to document what's going on with their patients are really, really good at reading between the lines of their own sketchy notes. They're busy people. They will use abbreviations. They will use obscure, phrasings. They will also imply things just by their own knowledge of how things currently work. So for instance, the question of does someone have cancer? You would think that that should just be a simple search. Well, it turns out to be astoundingly hard to draw a precise circle around people who've had cancer at Stanford. The doctors who are treating them know exactly whether or not they have cancer, but the breadcrumb trail that they leave behind in the EMR can be inconsistent and confusing. Same for something as apparently as obvious as is someone pregnant. It's not. It turns out that are you pregnant is one of the types of questions that they may ask you on a piece of paper, but it's not reliably documented in an electronic format in a flow sheet in the EMR. All kinds of things. See, your primary care provider, your obstetrician knows if you're pregnant, but if you then show up at the emergency room for a broken ankle, they're not going to ask you, are you pregnant? They're just going to focus on your broken ankle. Another pitfall is that, so I already mentioned that EMRs are designed for documentation and billing and not for research. So you need to bear in mind that your research question was not in the mind of the person who was originally writing up this clinic note that you're earnestly reviewing right now. So you're going to have to do a lot more digging. EMRs use codes for reimbursement. You probably already, everyone in the audience already probably knows this. That these codes are kind of coarse-grained. So the reason I picked this particular code, 174.9, is that that's actually the code for breast cancer and not for prophylactic mastectomy. But because there isn't a separate code for prophylactic mastectomy, they have to get reimbursed for these prophylactic procedures. And a woman comes in scared because her auntie and her mom and her sister all died of breast cancer. She says, take my boobs off. They need to get paid for having put her into surgery. They use this code to get paid because it's the same set of doctors and the same procedures and the same cost, the same amount of time and all the same operating room as an actual surgical removal for the purposes of breast cancer. But when you're a researcher, you want to know, did she ever actually have breast cancer? Was she cancerous or not? That code will mislead you. So you just need to be super careful when when using clinical data for research. I don't mean to sound like a broken record, but I mean, I could go on and on all afternoon. There are 10,000 tables in the EMR. Outcomes data tends to be incomplete or completely missing. Clinicians who have seen a broken ankle in the ER are not going to be following up on that patient 5 years, 10 years, 15 years from now. They're going to just hope that they don't come back. Social Security death data, which we have, is sadly very incomplete. There's this nice article in 2012 about how the rule changed at the federal level, and all of a sudden only about 30% of deaths in the US now actually are usable in this death data feed. So if you're using the death data in STARR, bear in mind it is underreporting the actual rate of death for your patient cohort. Then you have to always bear in mind compliance, and just basically be patient with yourself and with the data. It really does help to keep your expectations low. All right, so enough ranting. Why don't you guys figure out how to minimize the screen here, and let's dive in. And I think I will do the same. I'm going to switch. So what you want to do is you want to browse to this URL posted in the chat. Let's see if I can figure out how to do that. Ah, here it is, pops up chat. Okay. And when you do that.
And Susan, we need to be on full tunnel VPN, right?
You do. What's my local copy? Erase that. Right. What's going on?
That's the exact page that I just got.
Yeah, sorry, in the wrong URL. So that I will put a different one into chat. I must have. Yeah, that is a bogus URL. Sorry, my slide deck was wrong. Use the second. And this is the Cohort Discovery Tool. So this terms of use, there's a little story here I want to share with you. When we first rolled this tool out, it was really revolutionary. This was back before Odyssey was even a thing. This was when Zach O'Haney and Henry Lowe were still talking it through and trying to figure out what the best way of doing observational research was. We rolled out this cohort tool, and almost immediately a researcher by the name of Jennifer Frankovich realized that she could use it for clinical care, that she could look up patients like her own patients by doing these counts. And so she spent a whole evening patiently counting, well, how many patients who've had this diagnosis also had were given this drug, and how many of them had this follow-up secular. So she patiently came up with a hypothesis and decided that she had proven her hypothesis just by using the search tool and getting counts. She published a paper in the New England Journal of Medicine, and it made quite a fuss. And so hence this terms of use. This system was not designed nor is intended to support any aspect of patient care, and for its use in patient care purposes is prohibited. We haven't changed the wording on that in a decade, but that's the backstory. That's why it is there. So you dismiss, now that I've pointed this out, you now know why that is there, and you just dismiss it. So this is designed to be self-explanatory, but like all self-explanatory user interfaces, it is anything but. I'm going to start by going to the upper right here, click on the blue help button. This is handy. This documentation page is actually well worth your time. Sit down, pour yourself a cup of coffee or a glass of wine, and read through it. It's very detailed, very deep dive into all of the features of cohort discovery, and it actually will go into some of the underlying data issues that you should be aware of. This request a free consultation is your door to getting in touch with the Research Informatics Center. After we've done messing with the tools, I'm going to hand the podium over to Mina, and she'll describe what the consultation service is like. This viewer data timeliness report. This is an interesting one. We created this back when we were struggling to keep the lights on. We had months on end where we weren't getting clinical data in the research system. So it was getting staler and staler by the day. We have upgraded our infrastructure. We're now running on cloud. This is almost guaranteed to be today's date. But that's why it's there, if you are puzzled, if you're not seeing any recent data for your searches, hit that data timeless report, and that will tell you whether or not our research system is indeed up to date. Build info is boring, it's just for us. And then this tell us what you think is just a, type something in and it'll send us an email. Now, so let's dive right in. So the current age means the patient's age today. So we have, if you were listening to Nigan's talk this morning, you know it's all about patient timelines. We have the date of birth for everyone in the 3 million patient combined EMR. And so this current age constraint is going to calculate between today and when they were born, are they 18 years old or less or whatever. So if you want to restrict your search to a pediatric cohort of patients who are currently pediatric, then this is what you would do. It's rarely useful when coming up with retrospective study queries, but it's there. Also, I want to draw your attention to the fact that all of these constraints, so I should take a step back. So what I've done by clicking on something over on the left-hand side and instantiating on the right is I have actually created a cohort search. And then I can click on count, and it tells me that there are 670,000 patients in the combined EMR in this searchable, discoverable in this system who are 18 years or less. And
there's a question from Aimee. I'm sorry for pronouncing it much. She just wants to make sure that those are unique patients and not duplicated.
I'm sorry, you were fading out. Could you repeat
sorry.
that?
So there's a question in the chat. Aimee is asking if there's the patients are unique patients and not duplicated.
Correct. It is unique. When you search, do patient get duplicated? They do not. These counts are always unique patients. Great question. So the other thing you can do, let's not do it with this large cohort. The other thing you can do with a cohort, once you've got a valid search, is you can click this analyze button here. It'll take a minute, but then it will run some very simple queries for the top 10 diagnoses. The gender and race breakdown looks like we have statistically and probably more male babies than female babies in our EMR. Unknown, so this is actually pretty interesting. So this shows you clearly that race is not reliably gathered at Stanford. For whatever reason, their intake process is to leave it blank. I guess they just feel like they shouldn't be intruding on the patient. But be aware if you're trying to do something related to health equity or racial disparities in care, you may need to create a prospective cohort and follow up with them in person to actually collect race information. This is reassuring. It looks like our search worked and that everybody is less than 9 years old. And here's the breakdown of the counties. And then you can go on and say, I want to show top 10 lists. Let's see what we get. So it'll take a minute to load. So they're mostly taking sucrose is just a sugar drip. It's just, hydration. A lot of them are getting hepatitis B vaccines and so on. So this is your snapshot of, oh yeah, and a lot of them are jaundiced. So here are all the newborns. Near the single live newborn is the vast majority of the procedure codes. So yeah, this is sort of a sneak peek into the types of data associated with your cohort.
I have a question. Once you put in the age group, how do you get the search to go? Like right there, what did you push to say go?
Okay,
Count.
to count, if you click count, it will create this. Yeah, so it'll count inside the constraint and it'll count on top. So let's add a second constraint that's limited to females. And that number should get cut in half. You'll see that there's 19.7 thousand patients who are 1 year old and 2.4 million females, and only 9,000 of them are both. So this tells you that when you instantiate more than one of these search constraints, it's doing the intersection. It's taking the overlap between the two. It's an and, current age less than equal to 1 and female. There is, let's create another, how about race?
I got a question from Sonia. She just wants to check. Sometimes when you push the count button, you get a different number. It's slightly different, which may be why the.
Oh yes, thank you.
approximate-
Great question. This is brilliant. So what it's doing is you'll see the tilde, the twiddle in front. That twiddle is computer software speak for approximately. You'll notice, look at all these numbers, they all end in either 5 or 0. We are deliberately fuzzing that number. So if the count comes up different the next time, then you know that you're right on the cusp, that the actual count is like suppose it flipped between 280 and 285. That tells you that it's either 282 or 283, and that our algorithmic fuzzing to try to make sure that you don't get an exact count is indeterminate. And sometimes it fuzzes up, sometimes it fuzzes down, and that's why it jitters. The reason we're doing that is it is for HIPAA. This tool is anybody with a student ID can log into it. We don't want people using this to figure out whether or not Michael Jackson was seen at the sleep clinic here. By putting in enough precise terms, and if we had counts that let you figure out exactly which, if we reported exact counts, you may be able to figure out the one person celebrity that you're snooping on. So that's why we do it. All right, so race is an interesting constraint. This allows you to select interesting. So yeah, this is actually a little inconsistent with some of our others. So in this version, if you want to select more than one, you have to select them from a checkboxes here. The other way that we support creating a bigger cohort is if you pick the clinical event diagnosis, you'll notice and start typing. Type in, I don't know, diagnosis of, I tend to use diabetes or worms. Here, let's type in worms. Interesting. So cestode is not, in fact, see, sometimes that's part of the problem is that, so a cestode is a type of worm, but looks like there's no synonym in the clinical vocabulary that tells you that. So when you are building these cohorts, you should do some, don't rely entirely on this system. You should do your own research and make sure that you fully understand how the clinicians are going to be coding their patients. So anyway, let's search on armed tapeworm. If we get, let's see, this is likely to be less than 10. Yes, good. So, and here's another thing that we do for HIPAA reasons. If the count is less than 10, that is what we show you. We will decline to give you any numbers lower than 10. So you don't know if it's 0 or if it's just a really small number.
I have another question from
Yes.
to Dalola. If you pick an ICD-9 code versus an ICD-10 code, would you get both of the linked, the corresponding other version? Like if you
Let's, I'm going to talk about ICD-9 and ICD-10 in a sec. So this is, let's try hookworm. I wanted to illustrate this way of expanding your search, and then let's talk about codes. Huh. All right, cestode infection. It is cestode infections. Actually comes up with something. Oh, I know what the problem is. It's because I'm insisting on race. Okay, so there's about 65 patients with this diagnosis. And then if you see this gray button here on the right, you can type in something else. So you can say hookworm and then count, and it should come up with a larger number. So that's the way that you can expand your search. You can expand your search within a constraint, but if you're, and then you can be aware that you can add the same constraint twice. So if I now want to say, and no diagnosis of, I don't know, gout, you can do that. So you build up and you limit. So it's just a way of, it'll probably be the same 110. Yeah. So this was a no. All right. So the question was ICD-9 versus ICD-10. ICD-9 was in currency all the way up until about 2015, I think. And going forward since about 2018, no, I think they started to try to implement around 2015, but I don't think they really got much traction until around 2018. So starting around 2018, after 2018, certainly by 2019, everything is coded in ICD-9, ICD-10. There are crosswalks, but the crosswalks are, So yeah, I mean, this is one of the problems of working with clinical data for research. If you know both the ICD-9 and the ICD-10 code for your condition, I generally recommend that you use them both. But you can play around with it. So we had 4.5 million patients with gout. That doesn't make sense. Oh, no diagnosis of gout. Sorry, that's the entire. Let's see what, for this particular code, whether or not there's a reasonable mapping. So 27.9 patients have gout. Let's go find the ICD-9 code.
I would think if you're looking for really old patients, 2014, the ICD-10 codes are not going to be recorded.
The mapping is such that we walk across the crosswalk. So let's see what we get. Yeah, it's very similar. Very, very similar. It's 26 versus 29. So I think what happens is that if you supply the ICD-10, you'll get all the ICD-9s, but not the converse. So these ICD-9s are just the older patients, would be my guess. But again, that's why this is fraught. That's why Dr. Frankovich got in trouble for attempting to use this for clinical care. I don't have a crisp answer. You will have to play with it. And then you'll go into chart review and you'll review the charts, and then you'll really understand what the data is telling you. All right, so now that we have one of these clinical constraints up, I want to call your attention to this event, age at event. This is far more useful than current age as a rule. So here, if we say that they were between 55 and 60 at this is a query for people coded with gout at that age, and it'll shift. So it'll pick up patients who are being coded with gout in 2022, and it'll pick up patients who were coded with that 20 years ago, who are now in their 80s, but they had gout 20 years ago. So this is generally the style where you want to put in your age ranges for retrospective studies, because it'll pick up patients matching your study protocol across the whole patient timeline. Event date. So this is sort of the opposite. This will actually pin the data set between calendar dates. So if we wanted to say, oh, I'm only interested if they were diagnosed during COVID, then you could say 3/1/2020 and leave this one blank, because if you leave the second one blank, it'll actually treat it as a, or the other way to do it is say after. So that'll pin the search to that particular date range in the EMR. It will ignore all clinical records that are prior to that date. Rena, am I still keeping up with Mini, could you do me a favor and watch the chat and keep and let me know if anybody asks questions.
Yeah, I mean, there's some questions that I've been answering.
Brilliant. Thank you.
LPCH and SHC this is pulling from both of those systems.
This is pulling from both. And what's interesting is that there is still to this day no crisp way to differentiate. You can specify the clinic, and if the clinic is emergency perhaps isn't the best one, but if you happen to know that the clinic is an LPCH clinic, then that'll limit it to LPCH. But we don't yet offer a way of searching in this that's limiting to the EMR. It's something we're considering implementing.
I had a question. Is there an or function? So for example, if I'm an ophthalmologist, if you did papilledema, both eyes, papilledema, right eye, papilledema, left eye, I couldn't figure out how to do that. So
how do you spell it?
Like pseudopapilledema, PSEUDO, papilledema, ILL. Yeah, so if I want all of those, like I want to figure out how many people have been coded for all of those, do you have to do separate diagnoses of?
So what you'll do is you'll pick the top one. Okay, so let's talk about this. So this diagnosis codes are hierarchical. See how it says H47.33 is pseudopapillema of optic disc, and 331 is right, and 332 is left, and 333 is bilateral. If you pick this top one, Stride is smart enough to get them all.
Oh, that's interesting. Okay.
Yep. It won't pick up this one, however, this 377. Look, it's a different structure. So what you want to do is you want to pick the top one, and then you'll want to click on this little gray plus box. And then you'll paste in your term again.
Oh, there's okay, that's what I was looking for.
Yeah, this little gray plus box here is how you have how you expand your search.
Thank you.
You're welcome.
And then if you wanted to do an and between the conditions, you would add another diagnosis box, right?
Correct. So if instead you wanted to restrict, so this plus box will make a bigger count. Let's get rid of this guy. But if instead you wanted to limit it to the intersection, you would put them side by side, and that's doing an or, an and. I'm sorry, that wasn't helpful. So yes, occurrence frequency. Let's talk about occurrence frequency. Oh, interesting. Yeah. So there's no overlap. Oh, it's just that H47 isn't used. That's interesting. Yeah. So that's something else that you need to play with. You need to figure out which codes are actually used in your clinical practice. If you hover over this little blue eye, what pops up it changes between different constraints. This particular constraint shows you how many diagnosis codes we've accumulated over the years. You'll see there's a little thin blue line all the way back to 1990. We do have diagnosis codes going back to 1990, but there's so few of them there. It's in the noise. Actually, weekly accumulation. That's right. I meant to ask that this graph be updated. So they didn't accumulate much over time, and then they started accumulating at a very, very rapid clip, which is why we have this occurrence frequency is.
There's a couple of questions
Yes.
about diagnosis, and I just realized you're about to answer some of it. Is
Yeah.
Is it just the first time the diagnosis is recorded, or is it pulling from every, like the age range? Is it going to pull when it's first recorded or whenever it's mentioned? And then what kind of diagnosis, problem list versus billing?
Okay, so that's starting to, let me read the question. Does the date range here apply to just the first time the ICD-9 is applied to the chart, or every time it comes up? The latter. So I see this, that the person who asked this question knows that codes will be repeatedly applied to the same patient over time. This event date range is simply throwing out data prior to, that's outside of your specified range. But then if a diagnosis code of the type that you're searching for is within that range, it'll absolutely count that patient. So we do not yet have a way of specifying that the first diagnosis was in that time frame. That's a really good question. Problem list coding versus what coders attached to record, what is captured. We do have problem lists, but I don't think, no, we're not. We've talked about exposing problem list versus other types of codes in this search tool, but we don't yet have it. That could be an enhancement suggestion that comes out of today's meeting. But yeah, problem list codes are absolutely included in this search, but so are reimbursement professional billing codes.
So can I just, thanks for that clarification. So if a physician puts a diagnosis code by accident in, for example, and then it turns out, the patient has his time course and a coder goes back and determines he or she never had that problem, but that patient will come up as having that problem in this search?
Potentially, which is why this occurrence frequency is here. So if you're concerned about outliers that should be ignored, then you're going to want to say, okay, look, I'm only interested in 3 or more. If the patient has been coded for this condition 3 or more times, then I know for sure that they have the condition. It's not ideal, but it does, yeah, it's.
Can you just clarify, for a single hospitalization, let's say a patient has a UTI, that will be coded multiple times during that one stay, or you're saying he or she has to be readmitted, or has to had 3 different admissions with a UTI?
I
think it's every mention of it in the EHR, right?
I know that's a really good question. If it might depend on the length of their stay. If they've been in hospital for 6 months because they were in a coma and they've been in the ICU, I think they periodically will break up that they send bills, right? This is a system for billing. So they will break up those longer stays into bills, and they'll send out monthly bills, and then they will recode every month. But if it's a short stay, it should only happen once. That's my guess. I don't work in billing. I don't work at the hospital. I'm just an informatics person who's seen a lot of repeat codes. But I've got to admit, that's why, back to my soapbox, it's difficult to use this clinical record for research without really digging in and really understanding the clinical patterns and billing patterns that produced it. I don't have a crisp answer, I'm sorry. All right, I think we have sucked this one dry. Lab tests. Lab tests are fun. So we have, again, you can either pick no lab result or lab result. And then again, you just start typing, I don't know, glucose. And look at all these glucoses. Isn't that exciting? And so the problem with labs is that you need to know which of the glucoses you are ordering. Let's try glucose serum plasma because I'm pretty sure that that is one of the ones that is abnormal. That's fine. Let's count. So this can be challenging as well. Yes, I got lucky, but it can be a real patient. You have to be patient and sift through all of the things that result that hit your search term before you can get a crisp answer. Because this is numeric, I picked a numeric lab. You get these numeric things. So numeric lab results will come coded as abnormal, high or low. You can ask whether or not the lab has ever been ordered. That's the exists clause here. You can say, it was between, and this is where I have no idea what glucose lab results are supposed to be. So I'm just making up some random numbers. But if you specify a microbiology lab, I don't know what, C. diff maybe. Yeah, let's try that. You'll see that it changes. All right, that's embarrassing. This could be interesting. Oh, hey, sweet, we're actually doing really well. So not so much C. diff in the 20 years of, that's really encouraging. So yeah, so that's, be aware that if you picked something and it doesn't come up with the drop down that you expected, it's because you've selected a microbiology, a quantitative lab, like a culture, as opposed to a qualitative lab, like red blood cell. So we offer searches on both. And the big one that everybody was searching on over COVID was this one, SARS-CoV-RNA, and I'm pretty sure this was, yep. So that's also, it was, the COVID test is just exists positive. All right, now I'm curious. The temptation is to just snoop is almost overwhelming. Labs are, the reason we do it with, yikes. The reason we do it with just keyword search is because at the time we built this, LOINC codes were not a thing. LOINC has since been sort of implemented, but it's still just a really, really small subset of the most popular labs. But I do have a plan to, like when you see this glucose, this intimidatingly long list. We are planning to beef this up and add a little bit more information here to tell you which ones have LOINC codes, which ones have been ordered recently, and so on. So yeah, we're going to make this a little easier to navigate. A lot of these have almost, are such obscure labs that they have relatively little data. Yeah, you see, there's labs in the list for which there are relatively few patients. So it can be a bit of a hunt and peck. Are there any more questions on labs?
Not on that, but there's a question on the temporal constraints.
I'm sorry, there's a question. In pairs of events. Okay, we'll get to that. That's a whole, this whole temporal constraints. That's, let's walk through the list and talk about each type of constraint in turn. Okay, let's start talking about drugs. All right, so again, you can select either with or without, including exactly matching. So the thing with drugs is that they tend to be compounded. They tend to create these cocktails for people with multiple drugs in a single administration. And so the way we, and the list of these drugs in the EMR is intimidatingly long. I mean, it's tens of thousands of different terms, and there will be literally hundreds of variations for the more popular drugs, like aspirin literally has over 100 formulations and variations and doses and routes, and every single one of those combinations is a separate line. So what we did, it actually took a lot of work, took several years to get it right. We published some papers on it, is we've mapped all of both hospitals' drugs to a controlled clinical vocabulary known as RX norm. RX norm takes all of these formulations and knits them all into the actual active ingredient. So if I type in a brand name like metformin, Fosamax. Oh, okay. No, I thought it was Fosamax. Anyway, if I type in Lexiva, which seems to be a brand name for something, it's actually going to prompt me saying, oh, well, do you mean Lexifen, which is lidocaine plus menthol, or did you mean Lexiva, which is this ingredient? This is the Fosamprevnivir, is the actual chemical, the psychoactive or clinically active chemical that you're administering to the patient. So all of our searches boil down to that ingredient. And then actually let's use aspirin, because that's one of the aspirin. S-P-I-R-I-N. All right, so this is a good example. So here you can see that we've rolled up a huge number of different ways of referencing aspirin into this one. But here's a combination of aspirin plus acetaminophen in the same pill. And here's aspirin plus acetaminophen plus caffeine in the same pill. So you can scroll through this list. If you are only interested in one of the drugs, obviously you just pick it off the top, but you may in fact be interested in the administered combination. So we've tried to be faithful to actually keeping every single documented combination of drugs. So they're all here, but they're just going to be in what may be an unusual, like if you were expecting to see Agrinox, you're going to wind up seeing aspirin plus pyramidol, but you will get the same information. And then be aware that when you're doing chart review, you're going to see the actual brand name a lot of the times in the actual chart. So don't be puzzled by the fact that the charts don't use the term the ingredient term. They will tend to use the brand name instead. So that's just something to be aware of.
There's a question about whether this is pulling from OMOP, if it's OMOP based, or FHIR, which I don't know what that means, but it's not OMOP based, right?
It is not. So STARR is definitely not OMOP. It is not FHIR either. We have our own, we call it the legacy data model. We've built our own little OLAP database out of Epic Clarity. We do not use FHIR for this because FHIR is a real-time protocol that is one patient at a time. And in order to do searches across an entire EMR, you'd be sitting here for 24 hours waiting for all 4 million fire queries to come back. So we've got a data warehouse using our own quirky data model that lets these responses return really, really, really quickly. But it is the same data. And we are, over the summer, we are starting a project to use OMOP. So we're going to move all these tools over to use OMOP as the foundation data model. But at the moment, we're using a different data model that we invented. Drug class is an interesting one. So we originally, back in the day, decided we were going to do something fancy with the controlled clinical vocabulary, SNOMED. But then EPIC stepped in, and EPIC has a therapeutic class associated with every single drug. And so this just lets you search the EPIC therapeutic classes. So you can search for antifungals and you will get the antifungals in EPIC. So this is, it's called class for historical purposes, but it's actually the, the therapeutic class as defined in the EPIC medication list. So this is very tightly tied to the current EMR. Oh, wait, sorry. This any route thing, sometimes it matters if the aspirin was administered orally or nasally, so it's here. Yeah. But bear in mind that it may not have been documented, so these filters may filter out more than you were expecting. Clinical documents. So this is, are there any questions on medications?
Yes. Sorry, there's a
You-
question about, can we exclude medications?
Yes, I think so.
Like CNS?
Yep, no drug with ingredients.
Okay.
Yeah, they're almost all of them have it.
But can you do a class like all of CNS?
Exclude a class?
Yeah.
Yeah,
Yeah,
sure.
okay.
And, they all have it. This is pretty much standard. That. Yep.
Okay, and then there's another question not really related to medication, but this includes all the affiliate data with UHA and Valley. Is that right?
Yes, it does. STARR does contain charts from UHA. That's, remember we looked at those, that graph of the skyrocketing rates of numbers of patients that we've collected over the years. That's almost all due to the hospital haven't been adding beds. So it's all about these PCHA and UHA clinics. That's where we're getting all of these extra patients come from. Does STARR include data from Care Everywhere? Absolutely not. Care Everywhere is a clinical only, break the glass. You are logged into EPIC and you get to inspect a little box opens up and you can read that patient's note. It's in a private sandbox that only you can see. It is not part of Stanford's medical record. It is for clinical care only. I'm sorry. I'm going to close the chat window again and go back to clinical documents. Okay, so clinical documents have this ontology that we made up. This is very old. Clinical notes, radiology reports, and pathology reports are the top level headers. And within clinical notes, you can pick any of the following discharge summaries, telephone encounters, blah, blah, blah. Other note is a catch-all. So if you want any clinical notes, you would, but you don't want radiology or pathology reports, you would tick any clinical note. And so this will give you all, it'll let you search on all clinical documentation, except it won't be searching on those radiology or pathology reports. Now this keywords search is doing the simple thing. It is looking for, I don't know, let's see, for instance, you only have two choices. You can either say, I want that exact phrase. I want those two words right next to each other with a space between them. Or you can say, I want, if it mentions both liver and biopsy in the same page, that's what I want. and they come up with very different results because if you're using the in same document, be aware that you are going to get, no, let's do the counts. I'm expecting to find more. So 75.3 versus, I expect this to be slightly less. And again, you won't know until you actually do chart review why the, whether or not the patients you're interested in, half from 75 to 60 to 36. So you'll get twice as many patients by using the loosey-goosey search for multiple keywords, but you'll have to sift through a lot more patients that actually aren't what you're looking for. So again, it's up to you. Let's see. Encounters. This is an interesting one. So you can say no encounter with. You have to specify whether it's with a clinic or a provider, although you can pick both. So we could say emergency department with provider name. I don't know, does this person, this is just on my search history. I have no idea whether or not they're an emergency department doc. So yeah, this lets you, he is an emergency department doc. Look at that, 80, and he's been busy. That does not look right. Oh, or, got it. So this is actually an or. Okay, that makes sense. So that's really interesting. One or more. So yeah, this is or, not and. So if what you wanted to say was, I want to see people seen at the emergency clinic by that provider, you need to do this. And then we'll count that. There you go, 35 patients. So if the number seems surprising, double check your assumptions. And we are poised on the cusp of releasing an enhancement to these clinic names that will add a lot more information about them. It'll add how many patients have been seen there in parentheses, and it'll also add the location in square brackets, and then it'll add at the very end the year range that the clinic was active. So I think that we're launching a quality enhancement effort to systematically go through all these lists and beef them up, make them easier to interpret. And like, for instance, these providers, we could be adding their specialty. We should be adding their specialty, but it's not there yet. Let me quickly check. No new questions in chat on it. So that was encounter. Hospital admission. So here, what we're doing with hospital admission is we're looking in the encounter record. Every encounter at Stanford Healthcare has an admission date and a discharge date and time. And this will let you winnow it down to someone who has at least spent the night. And this will let you focus on outpatient, on people who were admitted and discharged on the same day. But you may be interested in just any length of stay. So those are your three choices. And again, you can negate it. And vital status is, yeah, are they alive or dead? And this is going to be this deceased. That's a strange graph. Why is it? Indicates whether we received notice that patient died, no surveillance is implied. When they're available, we use list of retired Social Security numbers from the Social Security Administration. I need to figure out why this chart is looking so flat. Oh, I know why. Okay, so see over at 1990, there's a huge bump of, I'm guessing that it's 15. Yeah, I have no idea what this graph is attempting to show. I'll have to check with the engineer who put it here. But this is just indicating that the Social Security Administration death information is being consulted in this metric. So let's see how many dead patients, whoops, who have had any hospital stay do we have? Okay, so we have death records on 216,000 out of our 4 million patients. So a tiny, tiny fraction. And 109,000 of them, of our 1.6 million hospitalized patients, are included in that list. So half of them were hospitalized at one point, and the other half weren't. All right, so now we're finally getting down to the really interesting question about pairs of events. Let's find a pair of events. So let's say diagnosis of, go away. I don't know, glaucoma. And a hospital length of any stay. And I want to know if the most recent diagnosis of glaucoma preceded the hospital stay by less than 5 days. So and this is where you can specify the earliest and the blah, blah, blah. What's interesting about this constraint is that you can't, that event date, the event date limits that the person is asking about is not part of this. So it can be, anyway, so yeah, this is how it works. This is, let's count how many patients we get. So this is looking for co-occurrences within a time frame. Yeah. So 2,500 patients had a glaucoma had their first glaucoma diagnosis right before they were hospitalized or admitted for any, and yeah, as just perhaps just checked in and then checked out again. But if they're an admit of any length stay, implies that they were seen here at one of the hospitals and possibly also at Valley Care, as opposed to at one of the clinics, the UHA or PCHA clinics. All right, are there any chat we got here? Okay.
There's one from Sonia, but I'm afraid I don't quite, I thought we'd answered it, but.
Okay.
I actually
So
have
if a diagnosis,
may I just kind of summarize it? So one was, since we are on pair of events, I had asked a question earlier and you said you would come back to it. So I'm trying to ask there's the earliest and there's the most recent.
yes.
Which one is more specific and more restrictive as a search? Because I've had sort of different opinions on that from people, who I've gone in for a training with. And so I've had one says the most recent and one said the earliest. So I thought I'd ask you that question.
I can't hazard a guess. I'm sorry. I would recommend, if you are not sure, is that you save both cohorts, give them different names, and do chart review to see which one seems to fit your use case better. It may depend on the clinical practice of the disease group that you are studying.
Okay, and then the other question I had is about drug class, which is it possible to include more classes of drugs? For example, I think everything's been put under one CNS category when actually, I was looking for specific classes of drugs.
Yes, so there's the little gray plus box on the drug class widget is there. So you would just type in your two
Right, but the
It's like
options are not there. That's what I'm saying. So it's like,
options.
yeah.
Well, so what are you searching on?
So let's say, you're looking at medications used, antidepressants, right?
Anti. I see. You're saying that because antidepressants is not listed as such here,
Yeah,
but
so
you're
I
hoping
was
for a
just
different
wondering.
list.
Yeah, and then so everything's classified under CNS drugs, which is a big category.
Okay. So in order to, so this is the list that is in Epic. So we're just bringing it in from Epic. So in order to get inside CNS drugs, you would have to use the drug ingredient brand. You'd actually have to search on individual antidepressants, come up with do the research to come up with the sublist that you are interested in and type them in one at a time.
Okay, thank you.
You're welcome. All right. Georgia, is it possible to ask for 2 of the same lab result findings separated by a minimum time period? Tell me more. 2 EGFR results of less than 60 separated by at least. Absolutely. Yes, let's do that. So we're doing 2 lab results and we're saying this is an EGFR and it's less than 60. Chat. Less than 60. And lab result EGFR less than, oops, sorry, 60 events. So it will by default, when you first pull it in, it'll by default populate this one with the first and this one with the second. So even though they look the same, they're different. So for example, by at least 90 days. More than 90 days? Was that your license except for at least 90 days? Yeah, okay. So let's see what we get. Oh, and sometimes you'll see that the count button, let me do that again. You see the count button was grayed out. And so if you are typing something and then you like try to mouse up here and you're frustrated that it's not counting, hit tab. It takes you out of the text box and it turns on. Oh, sorry. Right, that won't work. So the earliest, well, we could, why don't we say any? And count again. There you go, 70,000 patients. I would love to hear the how to do that. How to do what? Sorry, Sonia.
Sorry, I was actually responding to Amy if you already have a cohort saved but need to.
Oh, okay. Yeah. So that's brilliant. We're almost there. That's the saved patient list.
Sorry, there's a question from Daisuke too. To Tola.
Nina, can you say that again, please?
Yeah, there's a question from Daisuke. Trying to get back to it. If a diagnosis is made during a hospitalization, does the hospitalization precede the diagnosis, or does the diagnosis precede the hospitalization?
You're asking me to build that query?
He's just wondering, and
no, so I'm asking, so like in your specific question or the query that you did, you had glaucoma and hospitalization, and then if that patient had the glaucoma diagnosed during the hospitalization, if I do a query saying glaucoma, if I do a query saying glaucoma diagnosis before hospitalization, does that capture that patient who had the glaucoma diagnosed during the hospitalization? Or do I have to say the hospitalization preceded the glaucoma?
Well, okay, so diagnosis of, you have to be very careful how you phrase these. So let's say a hospitalization, and then pair of events. So you want the earliest diagnosis. What was your question? How would you
So
phrase it?
let's say you do that query that you're doing right now.
Uh-huh.
Will that capture the patients who had the glaucoma diagnosed during the hospitalization?
No, it'll rule them out because this is saying that they had a diagnosis prior to their any admission.
Right. So how do I capture someone who had the diagnosis during a hospitalization?
You would say follows.
Got-
That their
Okay.
So
earliest,
the, is the admission,
earliest
the
diagnosis is
admit?
after the admission.
It's the admit date, right?
Yes, in these cases where all of these, so everything under clinical events has an associated date, and this temporal constraint pair of events is always referring to those implicit dates. So I think to capture people who were diagnosed in the hospital after admission is captured by selecting follows and
Got it.
making sure
Okay.
that
So
you pick
the
earliest.
admission is the admission date, not the discharge date.
That is correct. Yes. Yeah, no, I mean, we need to add discharge here, don't we? That's a really good point. I will have to look that up, but I'm not 80% sure that you are correct that it's that we use the admission date because we phrase it as admission. So that's the sentinel event is not the discharge. We should add it. Yeah, that's a really good point. We should add discharge as a, have a hospital discharge in this little drop down here. We should absolutely augment that. That's another really good enhancement idea. Okay. Quickly, before we get to save patient lists, I want to, just for the purposes of being systematic, I want to point out that the Precision Health Biobank has a couple thousand patients, 3,000 patients that you can request their samples, and they are queryable here. All right, so now what does this saved patient list even mean? This query lets you pick one of your, I've got a lot, saved cohorts and use it. Let's see how many patients are in this one. Use it to, so you've saved your cohort. We're going to talk after this is, after we're done here, we're going to talk about how to save a cohort. It's too small. Let's try that one. And then you can do searches on it. So we can say how many of these 30 patients have had a diagnosis of glaucoma. It's just something that you may need to do. So how do you, are we done? Can I move on to how to save a patient list? Are we done with chat for
I
now?
don't see any questions.
Okay, brilliant. So what you do is you go up here in the upper left under this little heart stamped folder, and let's quickly go through all of these options. So if you want to wipe out your search, you want to throw away everything you've done, you say new search and you say discard. Once you have you've done some kind of search, you can save it, give it a name, and then when you save it'll show up in your recently saved searches list here. And if you click on, if you have a lot of them like I do, it'll actually pop up a much longer list of all of your saved searches. Public library. When you save a search, you can tick this box. You have to give it a name, and you can tick the box saying save the search to the public library. If you do that, it becomes discoverable by everyone who uses the Cohort Discovery Tool. So here's what we currently have in the public library. It's surprisingly long. People are keen to use this feature. But yeah, it's all here. Catherine has been saving a bunch of honest broker queries and sharing them with her The Honest Broker is a service to let you reach out to large groups of patients that you have no immediate clinical responsibilities for. So it's a way of recruiting patients in a HIPAA compliant manner, and they use this. So these are all searches that you could pick up if you knew who authored them and you thought they were useful. Save patients for chart review is how you save your current query. Upload MRNs for chart review is another option. Sometimes you wind up with a list of MRNs that you've obtained from somewhere, from an ACE search, or from talking to the people in radiology about, getting, an extract from radiology, whatever. You may wind up with a list of MRNs. You can simply upload them. You have to give the cohort a name, you choose the file, and you would type it in. But for now, let's experiment with, I don't want to save that. Let's save my classic. I'm going to save. So yeah, come up with some kind of cohort that you would be interested in reviewing. And the very first thing right after cohort name, you're going to see this IRB or DPA number. Now, this is where you wind up you have to attest to the fact that you understand that you may be exposed to protected health information before you're allowed to actually review charts. And the reason we do this is because we do offer de-identification services, but by their very nature, they are unreliable. And I absolutely guarantee that even if you've opted to be reviewing de-identified notes, you will run across something that is identifying. It could be that someone slightly misspelled their name, like Mr. Stevens with a V instead of a PH. And all of a sudden, you know that their last name is probably Stevens with a PH. Or one of my favorite examples, and apparently this actually occurs somewhere in a radiology report. It was my pleasure to meet today with your patient, the CEO of Apple. And it's like, you don't just. And they really did. They really typed that into a note, and it's there in our EMR. And when you come across it, you'll know exactly which of your de-identified patients you are currently reviewing. So you need to sign this attestation saying that you understand that this is sensitive and that you're promising not to post it on the internet, and you're promising to not reuse it for other purposes than answering the specific clinical question that's currently in your mind. And so there's a bunch of do be careful with this data questions that you need to acknowledge that you've answered. So let's go do that now. So I want you, let me flip back to my little slide deck here. Oh wait, yeah, so here's some prompts. Searches don't autosave. Oh, right. So before we leave the chart review tool, be aware that there's no autosave on this. So if you are interested in the queries you've been running, don't just walk away. Your browser might crash and you'll lose it all. Do remember to save your searches. See this box. Right, and be aware that although diagnosis codes are hierarchical, which is super nice and super handy, and that makes searching on diagnosis codes really easy, procedure codes are not. They tend to be a mishmash of these 5-digit numbers that can be really hard to understand. And so soon, like as soon as next week, I hope you'll be getting an email from me saying, dear Stride user, dear STARR Tools user, we've released a new feature that lets you search procedure codes by keyword. So drugs are okay. So I covered all those points. So yes, compliance.
Sorry, there's
so,
one
yes.
question about why is there a restriction on the size of the cohort saved?
Oh yeah, because of chart review is intended to. You're supposed to actually be reviewing them it really wasn't intended originally to let you just download the data in bulk. Creating chart review cohorts places a significant strain on our infrastructure. We have to do a lot of indexing and aggregating in order to support chart review. So it just seemed like a reasonable number that more than one person can review in a short period of time. So yeah, and also limits privacy risk. It does slow down the tool for everyone. Exactly, it's a performance thing, and it seems to mostly be working. The people who are unhappy with it go to the Research Informatics Center, and Rena will be telling you all about getting large volumes of data out using her services. But these self-service tools are really designed for very specific use cases. I should pick up the pace here. This is going much more slowly than I had anticipated. Let's very quickly go to this URL. I will put it in chat. And then I think we should cut this short and let Mina speak, because it's already, how are people doing on time? Do we need to wrap this up? Do people, are people feeling antsy? Silence. All right, I'm going to pick up the pace here. I'm then going to give Mina the floor, and then after she's done, I would be happy to stay on the line and keep talking. So everyone should go to that URL. This gives you a complete overview of how to get PHI in chart review. But for now, I want you to scroll down to, on the left, it'll say preparatory to research. About halfway down the data compliance menu, below determination of human subjects. So click on preparatory to research. And then there's some discussion about if you have a need for identified data, you can contact the Research Informatics Center. And then scroll down to the middle of the page, how to complete a new prep to research data privacy attestation. And I want you all to follow those instructions. You're going to be selecting the preparatory to research activities. I'll follow along so you can watch. So you go to your dashboard. And then you say new in the upper, right across the top. And you're going to, from the project type dropdown, you're going to pick preparatory to research activities, which is the third one down. And then just type in your own name. This is you. This is demo. Fewer than 100. And then this is an interesting section. So in this section, this is for the purposes of this demo, I want you to, the middle column, internal use at Stanford, just tick them all off. But it's just interesting to, what do we got here? Tick them all off, except other photographic images. That's meaningless. We don't have them in this. The reason that we do this is partly for minimum necessary, mostly for minimum necessary. So if your research question does not require looking at radiology reports, you should leave radiology reports unchecked. If you don't think you're going to be looking at narratives for anything, if you're just going to be looking at diagnosis codes and lab results, then don't check clinical narratives. And that will actually create you a chart review cohort that is missing that information, which is in fact minimum necessary. But if you do tick either imaging data or radiology reports or clinical narratives, note this advisory. It'll pop up this yellow advisory. Since you do not have an approved IRB protocol, clinical documents and reports will be anonymized. However, please be aware that anonymization methods are imperfect and you may be incidentally exposed to PHI. And then you tick off all of these. I agree, you read them. They were written by a whole string of privacy officers, and they encapsulate your obligations that you are assuming by signing this document, that you will not misuse this sensitive data, you will not redistribute it, you will not use it for any purpose other than as documented above, and that you will only use it for prep to research. And then you hit submit. And you should go back to, there's your DPA number. Now I want you to grab your DPA number, not mine, in your copy buffer. And now go back to the Cohort Discovery Tool, which was here. And searches, save patients for chart review, and paste your DPA number into this IRB or DPA number box. And this is going to be done. And now here, this is the other interesting thing. So specify PHI. This is boilerplate. It doesn't yet know that you've got a DPA. So you can attempt, because you only have a prep to research DPA, you're not going to get PHI. You can select these boxes till the cows come home, and I'm not going to give you any PHI. But these PHI are there in the eventuality that you have a formally approved IRB with an associated data privacy attestation that lets you get PHI. I am going to say I want death dates. And then other student IDs that can access this cohort. This is just a convenience. You can always add them to your cohort later, but if you have other people that you want to share this cohort with, you can type them in here. And then you say create cohort. If you ticked off the Social Security death dates, you get this pop-up warning you that Social Security death cannot be redistributed. And it is now creating my cohort. How are people doing? Are you successfully creating a cohort? Has anybody encountered any difficulties? I'm going to take silence as assent. And here you go. It says this prep to research chart review will expire on the 20th of June. So we have 90 days. Says it twice. And there they all are. Those are your patients. And yeah, you click into them, you can start reviewing them. And now I'm going to hand it over to Mina and let Mina do her song and dance. And then after Mina is done talking, I'd be happy to describe how to conduct chart review. But it's also really well documented on the internet. So Mina.
Okay.
And I will watch chat for you, Mina, and
Thank
I
you.
will yell at
Okay.
you if somebody types something into the chat.
Okay, sounds good. Let's see, over here, and can you, there.
Yes, we can see that.
Okay, and can you hear me okay?
Oh yeah.
Great, okay. So I probably won't be able to go through all my slides, but I'll try to hit on some of the key points. My name is Mina Liu, and I'm from the Research Informatics Center, which is called RIC, or RIC. And I'm a data analyst, one of several in our group, and we pull data for research projects. So we'll go through the workflow as best as we can, maybe talk about an example project and Q&A at the end. So, sorry, let me get rid of this Zoom. Okay. So in terms of why you would come to RIC, we do offer some free office hours where you can schedule someone on one time with an analyst to talk about any questions you're having with the self-service tools. Sometimes people come and they don't know how to configure the searches to get what they want exactly. Sometimes it's not possible. So we can tell you that. There is that cohort size limitation. It is possible to ask for an expansion or to ask us to create a larger cohort for you. And then people will come to us for just scouting around for a potential project to see what data is out there. We also, hold on. Oops. Okay, we also handle the ancillary data requests. So some of the images or other formats like the waveforms, et cetera. We also do the STAR OMOP data. There's the de-identified version that's out there for everybody, but we also have access to the one that includes PHI if you need to get more identified data. And then we also have access to some of the registries. The main thing that we do though are paid concierge data vending consults. So, either somebody will be like, I can't do what I need to do in self-service tools, or I don't want to, I don't have the time or like the skill set to do it. Then you come to us and we can pull the data for you and do all these complex searches and linkages. And then there's data we have access to that you may not see in STARR tools. Somebody was coming to me for ambulance reports, or some of the surgery detail is not in STARR tools directly. So, and then we have tools and where we can, focus what you're looking at and speed up the search process, because when you do download data from STARR tools, you're getting everything. And so you will have to kind of extract what it is that you're looking for. And then in terms of what we bring, we have that broad access to a lot of clinical data sources. We have access to the full Clarity, which is a copy of Epic and the data dictionary. We can find things. And then we have a lot of experience looking for this data, and we know some tables, or we know how to find the data, and we know how some workarounds for the messiness of the data. Okay, and in terms of where we might help in the process, once you've defined the research question, you can come to us to help with some of the preliminary data that you're looking for, the patient counts. You would go to privacy or IRB compliance for getting that information. You might interact with contact a statistician either in QSU or your department to get some of the analysis requirements laid down, and then you could come back to us to get the data and aggregate it and sort it and process it however you want before you turn it back over to the statistician for the analysis. You do your writing and then publish. So we would be helping out with that data, pulling the data either for the preliminary, prep to research, or the actual data after. So this was our hands-on portion. So if you could go to this link at the bottom, med.stanford.edu ric.html. Let me see if I can go back to here. So this is our main landing page. There's some additional stuff in there that normally isn't, but down here where it says submit a request, that's where you would start. And then you'd click there and you'd get a link to this page, which I'm going to just revert back to my presentation here. Okay, so this is the intake form. I'm going to go through it in more detail to give you a chance to ask questions, because forms are always, it's written by people who aren't anticipating all the questions. So, so for this form, we do at the very top, we do include some information like, oh, remember the STARR tools, and you can get that data, access that data without going through this intake form, and you don't it is accessible school-wide, but you don't need to submit this form in order to use it. There's information about it's now called Research Use Exceeds STAR Capabilities form, where you want to use EPIC for non-clinical purposes. In certain circumstances, they will allow you to do that, but you do have to file this form. And then, let's see, actually, I meant to go this one. The recruitment link is there. This is if you need to get their contact information, like their email addresses. It works through the STAR tools, the Honest Broker, there's an Honest Broker link so that you can create a cohort and download their contact information, but you will need to contact them at this email address. And then, fill out this form so we can track your case and then pull some data on your project, and then you can sign up for office hours so that, and I'll explain a little bit more later. Let's go back to here. So I don't know if anybody has any questions about this. There is a question about funding status, because we do want to get a sense of, is this a project that is going to be turning into a paid plan? People put I think there's a place for the PI versus are you the PI? And then there's like the person you want to contact, us to contact. Okay. Sounds like no questions. So then the next part of the form, if you scroll down, is this part where you would actually identify your question. And there's a green box here noting that you are not going to get a call after putting in this case, requesting filling out the intake form. You're going to get an email, okay? And that's where you'll get the link for the office hours. Then below that green box is a list of clinical ancillary data. So these are the other sorts of data that we can help you get access to. So there's, the stuff that's not available through STAR tools. You checked already, it's not there. There's DICOM data, identified OMOP with the PHI. There's Phillips monitoring for the vital signs, etc. Hemodynamics, et cetera. So you can just click on one of those boxes, and then you will, for most of this, they will ask for you to fill out another form, because there's some specifics that they'll need in order to continue processing this. Yeah, so let me go to the next one. This is a list of the data sources. So the Clarity, which we've talked about, and I just realized we actually have data earlier than EPIC, like Susan showed you. There's stuff from Cerner, and that we have some access. It's not as filled in as Clarity, obviously, but we have the radiology DICOM, we have vital signs, bedside monitoring data, and some of these are only LPCH and some are the adult hospital, or some are the both. The clinical photos, the DICOM images from the echoes, ECG waveform files, hemodynamics, blood transfusion, and then the cancer related. We have a lot of the Stanford Cancer Institute Research Database, and we have access to the tumor registries. And if there's something that you don't see on here, you can contact the STAR group and talk about getting access to it. This is in the bottom of that intake form. There's a clinical ancillary data catalog, and that's what these are from. I just pulled it so you could see, but anyway, I'll just skip over that time. Okay, so office hours. So in terms of like, once you've submitted the intake form, you'll get that email back. You check your email and you get your case number, and you can sign up for office hours. The office hours are free. If you are going to require something beyond office hours, then those might require funding. But the typical things that people would come to us for during office hours are, specific STAR tools help, like how do I limit what I download? Because there's way too much stuff. And the answer is you can limit on the time frame, and you can limit like the types of data, procedures versus medications. You can also limit which patients you download. Like maybe you look through them and only 5 out of the 20 have what you are looking for. But beyond that, you really can't. So you'll say which patients you want to include, and you can download their data within a certain time. But you will get all procedures or all diagnoses. There's not a way to like specify, well, I only want that diagnosis that I care about. And if it gets too onerous to go through, that's where RIC can do that for you. Sorry, when the larger cohort, which I explained that we can create a large cohort for you, and then setting the search criteria. The office hours is also meant as a time to take in the ancillary data requests. So, if somebody's going to ask for DICOMs, they need to have the accession numbers for those studies. We can help you find those. And, if you need some clinical data associated with images. And then the last thing, which I've mentioned, is people will use the office hours time to get a sense of like, hey, can you find the My Health messages? It's not something that's easily accessible, but is in STARR, but can you get them for me? And so we can do some investigation, see where we can find those, and also give you a sense of what you need to gather, what data you need to gather in order to come and get a work estimate. After that, we might schedule a project consult if we weren't able to figure out all of that during office hours. During that time, we talk about the project, talk about your goals for the project, and then how are you going to identify the cohort, what inclusion and exclusion criteria. We'll talk about what you need in terms of data aside from the cohort. What do you want to know about the cohort? What outcomes are you looking for? What codes would we need to pull in order to get the data? And then talk about what format you want the data to be delivered in. And then we'll talk about the finances for the project, how much time we think it would cost, and talk about getting a PTA for our time. So that first part of that cohort identification, there's different ways you could look at that. There's the typically people will have an index event. What is that date that everything is based off of? So for example, the first diagnosis of breast cancer, or a particular operation like mitral valve replacement operation. So that'll be a key date, and we need to identify that. Talk about the age of the patients in the cohort, 18 or older, less than 1 at time of procedure, or at the time of diagnosis. So always keep that in mind with the ages. We want to talk about the location. There's the adult hospital that we have data access pretty broadly. So make sure you think that through when you come to talk to us. There, you might want to think about the inclusion and exclusion criteria. Like one of the projects I did, she wanted to exclude anybody who had ever been admitted to the ICU, or talk about anybody who ever had ventilation. There's the temporal linkages, like in the search criteria, where you might want to have 2 events, with one occurring before or after by a certain amount of time. So think about that in your project. And then it's helpful for us to know what the patient counts are roughly. Are you expecting to get like 35 patients, 300, 150,000? That can affect kind of how we deliver the data. Certain things it's not going to be feasible if it's a huge cohort. Okay, and then when you go and figure out how you want to characterize the cohort, what's helpful is if you think about things in terms of these categories, try to find out the codes for these things in advance. I put in bold the ones that we typically use. So for diagnosis, now we're using the ICD-10 codes. If you want to go back in time, you probably are going to need to get the ICD-9 codes as well. Procedures, we prefer CPT. There are some locations that don't use CPT, so think about that. If you want to have like a cast a broad net, the medication, generic names work best. The labs, you kind of saw the mess. If you have a low encoder base name, is even better. The encounters, the department names, providers, and then we can also pull things based on the OMOP concept codes. And if you're familiar with the OMOP concept code, it's kind of a list of descriptions across all of these different categories. So there's an OMOP concept code for diagnosis, or they call it a condition code, and things like that. Okay, and then just a comment that certain things are easier to pull than others. So medication diagnoses, they're straightforward if all you want to know is like, did the person have trastuzumab, whatever I don't know how to pronounce it, but the trastuzumab, if they had that or not. That's straightforward. When you start getting into things like the operative data, the linking data, extracting data, de-identifying, that adds some more time to the project. So even though it may be the same data, if you start adding those things to it, it can get a little bit more of a bigger project. And then you would want to think in terms of your outcomes. What are you looking for? Typically, it's death dates. So I did want to mention the death data we have. We have the things that were noted in EPIC. So things that happened at the hospital. Sometimes the family will call in and say, my dad passed away. And then maybe that would get noted. Beyond that, we have the Social Security data, which, as Susan mentioned, is incomplete, but we don't have if the patient was not followed up, or was not even around in the Bay Area during when they actually died, we don't have that data. And so what a lot of times people look at is the last follow-up date. When did you last see the patient in person, or get confirmation that they were still alive, and that people use that if they can't get the death data. Sometimes researchers are looking at the new diagnoses. So again, those would be, you need some codes for that. The procedures, if they had a reoperation, for example. So, and then just want to talk about the data delivery specs that you might need. Typically, we deliver things in CSV file. It's a comma delimited format, just plain flat file, they also call it. But we can also do BigQuery data sets. Some researchers need things de-identified, particularly if they are working with outside companies or another institution. We can do anonymized IDs. We can jitter the dates, which means adding a random number of dates to every single date in a patient's record, so that the relationship between the dates changes equally. We could also do age at when something happened, so age at first diagnosis. And then in terms of where we would put it, we can deliver things in the Google Cloud Platform, either in a bucket, a storage bucket, or in a data project that you have. There's also medicine boxes, which is mainly what you use to deliver the data. And if you want something else, I think there's a data risk assessment that needs to be done, and to get that clear. But we could talk about it if that's what you need. And then I guess I want to get through this last one, because the project wrap up can take a while. There's revisions. We turn over the data to you, and there's going to be missing or incorrect data. There's data that you're like, well, I thought it would be a higher number, or why am I getting all these things that I didn't want? And so the data we give to you initially is going to need some looking through, sanity checks. Often when somebody looks at the data, they come back and say, oh, well, should we look at this? Or, what about if we need these new variables, and find out if they, when they signed up for the My Health app, for example. And then often people come back with controls, or, like, can you go add these patients that I forgot about? And if that gets, just be aware that can, if it gets to be a lot, it may be a new project, and we might need some additional funding, and maybe putting you back at the end of the queue. And to Susan's point, the data is messy. you're looking at data across, depending on your project, it's coming from like 2000, I'm doing a project that goes back to 2000, and the data changes over time. The places where these things are occurring change, the department names change. We've got different people over time with different workflows. And, sometimes you see the research project you're doing, I'm inpatient, but you forget about the outpatient clinics, or things like that. So just be aware the data's messy, and it may not be your world as you see it now. It has changed over time. And just be aware of that. This was the project I was going to mention with Becky Dang, newborn nursery weights. And, it just encapsulates a lot of what we talked about, that there was a whole lot of missing data. And we had to go back and look at a bunch of different sources, like the labor and delivery notes, flow sheets, other like maternity records. So it's messy. Things may not be there when you think they have to be there. They are not always there. So we did a lot of work there. And then this last slide is just a flow sheet or a flow data, whatever, of what you need, what the process is to interact with this. So you can just keep that in mind and refer to this presentation as needed. And then there are the links to our groups. So I don't know if there are any other questions. I went through that really fast. And Susan, did you have any?
Thank you, Mina.
Yeah. Were there any
So
questions?
I think there were
Mostly about the tools, right?
it was I think we're back to questions about the tool.
Okay, I'll stop
but,
sharing.
Let's see here. When you upload a list of MRNs to create a Cohort Chart Review, how are the STARR patient IDs assigned? It's in order. It's just 1, 2, 3, 4, 5. It's sort of random. Patient 1, the first MRN on your list, or is there some other method used to assign patient IDs? Pretty sure I would have to play with it. I'm pretty sure that patient 1 should be the first MRN on your list. But I honestly, I would have to look at the code. I don't think we made any effort to be systematic about it. Let me get back to you on that. Could you please clarify the best way to ask us for help refining cohort discovery searches? The help request a free consultation button within the cohort seems to go to a research IT form, but you've said ask the RIC. Oh, that's a really good point. We need to update that link. It's gone back and forth over the years. And currently the RIC is the unified front door, but you're right, the tool still sends you straight to research IT. So yes, please follow Mina's instructions until we push a new release of the software with an updated link. Yep, you're all welcome. And so thank you for coming. We're at our 2 hours. Feel free to drop off. Meanwhile, I'm going to go back to sharing my screen. And if you guys want to hang on, I'd be happy to talk you through what we missed on chart review.
Okay, can I actually ask a quick question for Mina?
Sure.
When we request help from Rick, like understandably, it's going to vary depending on kind of the complexity of the question, but what is the kind of typical time frame from like beginning to end? Beginning when we have the office hour to like when we can get the data back? Like
yeah, part of that is unfortunately the queue is can extend pretty long, but yeah, it really depends. I mean, some projects they're like a couple hours, like they really don't take that much time, and then some of them are much longer, and I would say long tail ends. So we delivered the data a while ago, but then the researcher comes back months and months after, and so I don't know if those are when the end of the project actually happens, but and that is partly controlled by the researcher, how much additional time they want to take the data.
Got it, I see. But it seems like on your end, in terms of like getting the data delivered to the researchers, it seems like it's a pretty quick?
You know, it also
turn
depends.
around.
Yeah, it really, I've had projects that take a couple of hours and then other ones that are, I mean, a 50-hour project is pretty long, but
Wow.
yeah, 50 to 100 hours.
Great, thanks.
And Mina, did you answer the question if there's a queue, a wait queue at how
There
long?
is right now, although we're starting to, get handle on things and start taking new projects. Any other saved patients? I made notes. Oh, did you see that, Susan?
Yeah. So
Yeah.
shall we talk about, go back to talking about chart review? So if you, let me share my screen. So when you first get into chart review, this is your list. And then to get into individual patient charts, you would click on one of these rows. To navigate between your various saved charts, you have to click here on this funny little black down arrow. To remove yourself from a shared cohort, you would click on this obscure little red button. This little gray button lets you invite others to view the same cohort. And it also lets you turn on active cohort monitoring, which is if you want to have this search rerun every day to see if any new patients meet your criteria and auto enroll them, you can just tick this box and your cohort will be kept up to date on the cadence and schedule that you specify. If you want to add MRNs to this cohort, you choose your file of MRNs and you just upload them here and they will get added on at the end of the list. Ignore this. This is just, you guys won't see this on Broker. Let's come back to search later. And then if you want to pull data out, this is how you do it. You just tick the check boxes and you click on the download button and then you wait for a few minutes and then you'll get this list of download buttons and you can download data one data set at a time to your laptop. But yeah, let's go into chart review. I had a question in chat about notes. So yeah, if you start typing, hello, this is a note. There's no save button, it just saves it. And now if we go back up here and we search on hello, it's interesting that the word hello, I guess hello appears in some telephone consults, but here it is here. That's your note, your user note had the word hello in it. And so it found that patient using that search. And no, there's no time limit. It'll stay so long as you don't remove yourself from a chart review. These notes will persist. Be aware, and this was pointed out to me by one of the users of this tool, that if you invite collaborators, they may wind up clobbering your chart review. So you need to be careful who you share your cohort with. You can better, if the idea of these original category things was that you would include them or exclude them from your study by selecting these, but a much more dynamic and useful way of tagging patients during chart review is to customize the tags. So if you or green mucus or whatever you wanted to say, you would type it in, and then you have to click this little plus box, and then it becomes a tag. And now this patient is tagged with green mucus. And so now if we go back up to the patient list, Man, that's annoying. I need to figure out why it's doing that. I want only to see patients who have green mucus. And there they are. So it's a handy way to tag stuff for subsetting for searching to, and then we'll say any here. So get back the list. And then be aware that when you first get into chart review, it is sorting by type. Do you see up here on the left? So you'll probably want to, the first thing you want to do is to sort by date, because that will make the chart make a lot more sense. And then, yeah, if you just select stuff, it's sort of organized like a mail browser where this is the list of items. And if you click on something up here, it shows you the details here. And you can CBC, you can search CBC, you can filter this list. So now the only things showing in the list are the CBCs, and then you can use your up and down arrows to rapidly scroll around, and it'll actually highlight in the note what it is you've searched for here. And then to clear the search, you click show all. And over here on the left, event filters. If you click on the, see how when you hover over it, there's a little thin line. That means it's a URL. So if you click on event filters, it turns them all off, and you click again, it turns them all on. Not many people know about that. And so every patient has one line, which is their demographics and social history summary. But yeah, if you just want to be poking around inside their diagnoses, you can turn off stuff by category here. And that'll persist as you go to the next patient in the chart, which is this little green button here. So now we're still just looking at diagnosis codes. I know that was really fast, but are there any? Oh, chat. Okay, yes, there are questions.
Do you want to click? Did you already show them how you click on the plus sign next to different category?
To add patients, that's up.
No. Next to the word procedure, for example.
Yeah, so you can open it up exactly if you actually wanted to only look for abdominal pain diagnosis codes. You can pick all the abdominal pain codes, but yeah.
And then you can use the green arrows next to the patient list.
Right, to keep going. But you'll notice here that this patient doesn't have any abdominal pain. And so the poor tool didn't know what to do, so it just turned them all on again. So it's a little unreliable. It really works better to use the search tool in the upper right. Sorry, so collaborators. Yeah, was your question about collaborators answered? To adjust who can see the cohort.
Yeah, I think it popped up after you said.
Okay.
Warning: be aware that they can mess up your cohort.
Yes. Yeah.
And if you want to delete a cohort.
Yes, well, so deleting a cohort, you wind up just removing yourself. You can, so once there are no collaborators on a cohort, it sort of drifts into obscurity, but we don't actually delete anything. It's all still there on the server. So I can delete this cohort by removing myself, and they sing save and dismiss. And delete, yes, except we're marking it on the server as no longer. And now it's really confused because.
Can you talk about, sometimes people try to add a collaborator and it doesn't work?
Yes, I can. Also, here's your quick, when you go to STARR Tools, it takes you to the Cohort Discovery Tool. Click this little drop down in the center here to navigate straight to patient chart review. Wait, this is actually identified. That's not good. There we go. when you try to add someone and they do not have add another collaborator, here we go. I don't know. If it's red, it means that this person does not have a valid data privacy attestation for this IRB. Oh, and he does. It just took a sec, but Joe does have a data privacy attestation for that IRB. So, and so do you, Mina.
And make sure it's the
I
SUNET
need
ID,
him.
not the email address.
Yeah, you see, Nigam Shah has not filled out one of these. I know that Nigam is his SUNET ID, so it's a valid SUNET ID, but he hasn't got a data privacy attestation for IRB 13655, and so that's why he's red. And order the way that you get to STARR tools. The way you add someone to an IRB is documented here under data compliance. Here you say, wait, no, sorry. You simply go to your, to prompt someone to add yourself to an existing approved chart review. Here it is, collaborative chart review. Cohort administrator must add the collaborator SUNET ID to the chart review. The collaborator must complete an add-on data privacy attestation as described below. How to add yourself. There are two ways. So you just read the documentation. You can either ask for your PI for the IRB number and complete this form just by filling it in, or you can have them send you the link from their data privacy dashboard. Either way works.
There's a question about, is there a limit on the number of cohorts in the chart review?
There is
Chart
not.
review?
Okay. It just scrolls.
Yeah, I think, can you show them? Because I think
Sure.
there's an impression that, yeah.
It just scrolls and scrolls and scrolls. It's a fixed width box, but when you're in it, if you have a scroll wheel on your mouse, or if you use two fingers on your touchpad on a Mac, it'll scroll.
Okay, thanks.
Anything else? All right. You all have my email address. You now all have Mina's as well. If you folks have any further questions, don't hesitate to reach out. And it was delightful spending this time with you all, and thank you very much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.